Okay, we're going to move to our last question, the last patient here, Harry. Okay, so Harry's going to be a 72-year-old male with type 2 diabetes and hypertension, but no cardiovascular events. So he's primary prevention diabetes. A1C 7.3%, blood pressure is pretty good. LDL is 110. His baseline was 164, and he had a 33% reduction on atorvastatin 10. We'll get to that in a second. His triglycerides are 274. His non-HDL cholesterol is 165. So you obviously see the discordance between LDL and non-HDL in him as a diabetic. And if you wanted to do his 10-year ASCVD risk, it's obviously terrible because it's primarily driven by his age, 72 years old. So he takes metformin twice a day, takes hydrochlorothiazide, valsartan, that should be 320 milligrams, right? Not 240. And atorvastatin 10 because he says he could not tolerate any higher dose than that. Now let's assume that he's new to you, and that's the history you get. So what change would you make in his treatment plan? 1, add a bile acid resin. 2, add ezetimibe. 3, add fenofibrate. 4, add omega-3s. 5, add a PCSK9. I expected to see it sort of all over the place here.
And it is.
It is. You know, because the unanswered question I didn't ask you is, who wants to go through a 2 or 3 month period of time trying to figure out whether he truly is intolerant to a higher intensity statin, which is what he really needs? So he says, I can't tolerate it, but he's new to you, and he says, I can only take 10. So should you, if he was new to you, try to see if he can take a higher intensity statin? Yeah, I mean, that would be, if he's new to you, that's what you probably should try to do. And that's always a painful thing to try to do because the patients are, you know, whether they have a nocebo effect or a true intolerance is hard to figure out, but it takes time to do that. But I think you should at least try that and see if you could get him on a higher intensity statin. But let's assume he's not new to you, and you did try all that, and you've been following him for a few years, and all you've got is 10 milligrams of atorva, and he's told you, that's all I'm going to take, right? And you've got those patients, right? That's it, doc. Not going to do anything else. So obviously the interesting thing here is he's got not only a LDL that's not optimal, it's 110, but he's got discordance with high triglycerides. It's not uncommon with diabetes to have that kind of triglyceride-rich lipoproteins there, high non-HDL cholesterol. And some of us tend to try to lower both if we can, LDL and non-HDL. And that's what fibrates and omega-3s have always tended to be used. So I'm not surprised that some of you wanted to use the omega-3s in him. Don't have a lot of outcomes data in this particular type of patient yet on adding those on top of a statin, but hopefully we will. We've tried the fenofibrate in diabetes. Unfortunately, the fenofibrate trial in diabetes was not in this exact patient, which is the one they should have done it in. They did it with lower triglyceride levels at baseline, but they should have done it with baseline 275, and they may have seen a benefit. But, you know, fenofibrate, depending on his renal function, is something that you have to consider as well, but that would have been a possibility. Bile acid sequestrant, glad you didn't do that one because the question was asked about bile acid sequestrants and high triglycerides. This would be the one where, yeah, you're probably going to push him from 275 to 300 or more if you were to try to use a bile acid sequestrant. Although colesevelam does lower A1C, and if you did have a lower triglyceride value, you could use a bile acid sequestrant for 2 things, lower A1C and improve the LDL cholesterol. So his hypertriglyceridemia makes that a little bit more challenging. I do think ezetimibe would certainly get him below 100 in primary prevention, so he could certainly go from 110 to 90 or so on that. The PCSK9 in primary prevention diabetes, this is a difficult area to know what to do. You'd probably do the ezetimibe first and see where he was, and then you'd have to consider whether you might consider PCSK9. But let me just say that he fits into that diabetes group right there where he should be on high-intensity statin, and he's not because he's on maximally tolerated 10 milligrams a day. But that's what what he should do. And there's plenty of evidence that that's what these kind of patients should be on. The question is, do the PCSK9s have any data in type 2 diabetes? Do they worsen diabetes? Do they worsen A1C? The answer is we don't think so. They lower LDL significantly, and that's been shown with Alirocumab and both Evolocumab in patients with diabetes or metabolic syndrome. The question I have for you, and I have maybe for you out there in the group, if we couldn't maximize his statin, and we used ezetimibe and his LDL went down to 85 or 90, would that be sufficient for you in primary prevention in this kind of guy?
Me?
Yes.
Personally, I'd be happier than I am right now, and I really would want that non-HDL. So this is a patient where I want that LDL in that range,
right?
And I really want the non-HDL to get closer to. I want it less than 130.
So how are you going to do that with him then? You might add ezetimibe, and that may get his LDL down, but it's not going to make this big an impact on his non-HDL cholesterol. So what does he need to do?
You know, this is probably somebody, and it's maybe not even a lipid thing. I think we really need to make sure that we control his glycemia better. And that will have some benefit. It may not make his triglycerides perfect, but it will have a beneficial reduction in triglycerides, and I'd like to give that a chance to work. His A1C is not that high, but I think this is a patient where I would want to be more aggressive with LDL lowering, and I'd also want to reduce triglycerides. I wouldn't commit to a drug. I commit to other management strategies through diabetes.
Yeah, it's sort of, we start stepping outside the box a little bit here when you look at these high-risk patients. He doesn't have established heart disease, but he's an older man. He could certainly have preserved ejection fraction with diastolic dysfunction, which is what the SGLT2s probably helped by using those kind of drugs in these patients and reducing some of their cardiovascular events. So the question is, do you start stepping outside the box to reduce cardiovascular events using some interesting and novel treatments that aren't necessarily lipid lowering? So that's just one other.
GLP-1 agonist or
GLP-1's
SGLT2
also been
inhibitor?
shown to reduce. So do you start working on the diabetes side with known drugs to also complement what you're trying to do on the lipid side? We don't have a lot of data on SGLT2s affecting lipoproteins, but we do on the GLP-1s. They do tend to have benefits in lowering triglycerides to some degree. I'm not sure the SGLT2s have proven that they improve triglycerides much at all. So, anybody have any questions about this particular guy?
Not necessarily about him, but in all these guidelines, it sort of says a comorbidity is diabetes, but we don't really differentiate type 1 versus type 2.
Correct.
And with insulin, our type 1s are living into ages that are approaching higher risk. So do we just treat all diabetics the same, 1 and 2?
I think the ADA and ACE generally say that you should. And what happens there is that most of the, you get the real type 1s. They tend to be a little younger and they've had longer duration diabetes. So this gets into the, your primary prevention diabetes, but are you new onset diabetes or are you 15 years into your diabetes? I mean, that's a big difference in overall risk. I mean, a longer term diabetic, even if they haven't had an event, tends to be a much higher risk in the short run than a new onset diabetic. Type 1 diabetes have a lot of non-vascular problems. They blind in their kidneys and their neuropathies and everything tend to be really bad as well, but they do get vascular disease too, and so they should be in that same. And then I don't know whether any of you see what I call the 1.5 diabetics. They're obese and they require a lot of insulin and they're almost insulin deficient, but they're obese and they're just a difficult patient to manage. But they're all very high risk, and I think they should be considered, even as primary prevention, a group that needs intensive treatment. If they can be on high intensity, they should be. And he's not, which is the biggest problem for him, and we're now trying to make adjustments on top of that. I think if his baseline, if he was totally statin intolerant and his LDL was a lot higher, so in other words, he got a 30% reduction taking 10 of atorva. What if he took 0? And his LDL was 140, 150. We might be talking about this differently, right?
Yeah, we
I
might.
mean, ezetimibe, bile acid, you wouldn't use a bile acid resin with his situation. Ezetimibe's barely going to drop him reasonably. you consider him high risk and you want him certainly well below 100, you might consider the PCSK9 if he was totally intolerant to statins.
And I'd switch to rosuvastatin in a heartbeat. I mean, it looks like he's only not tolerated higher doses of atorvastatin, which usually is a pretty well tolerated agent. It is a bit more lipophilic than rosuvastatin, so it might be worth. I mean, I'm an advocate of trying another statin almost always. And so if it's only one that they have had a problem with, easy peasy. We have lots of patients that have a problem with one that we switched to another one and had success. It's not foolproof. You still may have some problems with that, but I think some of the pharmacologic aspects of rosuvastatin might be very desirable in a patient like this, and it may allow you to go up on the dose.
Yeah, you could try the Monday, Wednesday, Friday with 10 milligrams of Resuva. You could also try 10 milligrams once a week. I mean, those are things for really statin intolerant patients. Those are all options, but he's at least taking 10 milligrams a day. But if he was 0, that would be other options we would consider, and maybe PCSK9 and him being such a high risk might become an option under those situations.
Maybe check a few other things like his thyroid function. Some people might be inclined to check a vitamin D if you go down that statin intolerant kind of pathway. At least he's taking his current statin based on this given information. So,
any other questions about this case or anything in general that we have sort of brought up with our 4 cases today? I think we tried to cover most of the statin benefit groups and how you might consider the addition of non-statins. Yes?
Can you comment now?
Yeah, it's on.
Can you comment on the which the inhibitors will you use, dose, and as
Which
far
what?
as your choice on the inhibitors?
Of the
There are 2.
PCSK9s?
That's correct. Yeah, there are 2.
Right.
Which one do you prefer? Why? The dose? Which dose? How do you determine I'm going to start on this dose and then things like that, please?
Yeah, well, the efficacy tends to be similar. If you use the top dose of Evolocumab and Alirocumab, they're pretty similar in their dosing. So you use 150 milligrams of Alirocumab, 140 milligrams every 2 weeks. You should expect the same response, excuse me, and the delivery mechanism is exactly the same between the two. The Evolocumab does have a once-a-month option. That patients, if they wanted to only remember to take it once a month, it's a larger volume, but they could take it once a month, and you can get similar efficacy there. The Alirocumab does have a lower dose. The question is, why would you ever use the lower dose? If you wanted lower is better. Well, sometimes if you get too low in LDL, sometimes having an option of reducing the dose might be a reason to do that. But I'm not sure most of us ever deal with getting too low in LDL that we would worry we'd want to reduce our intensity of treatment. Joe?
I'm going to give you a really terrible answer, but in the landscape where I work at, it might be who the payer prefers.
Unfortunately, you might get told which one to use by the payer. Yeah.
Yeah, that's a reality. We have an interdisciplinary team. So our nurses and our prior auth pharmacists know that information a lot better. We have communications. It's not always the pharmacist or the provider that's calling the insurance company. We use our total team resources to do that. But so I've heard some people say that in diabetes that Alirocumab might have less of an LDL lowering effect. I think that's sort of a little bit blown out of proportion because overall, given most patients, I think they are comparable in their overall efficacy at lowering LDL cholesterol. Some other providers may say, I'm going to go with Evolocumab because it has the long-term data out now from the Fourier. I'm happy to get either one for my patient, and I am okay with if insurance dictates which of the two. That's sort of just my
If you're an outcomes guy,
perspective.
there's one with outcomes. That's the Fourier, and that's Evolocumab. So if that's the way you want to go, but a lot of times it is driven. You'll write a prescription for one, and then the payer comes back and says, we only have the other one on the formulary. And you go, oh, okay, well then it's fine. I'll take the other one. Does that answer your question? Okay.
Yeah, how you doing? Yeah, quick question about the Jupiter study. Just want to talk about that a little bit, since we know in that study many of the people who took Resuva who had metabolic syndrome were tipped over into diabetes. So I wanted you to comment on that because many of those folks, I'm sure, if you plugged them to that ACC-HCA guideline, would have high risk. So comment on that, please. And we know pitavastatin doesn't tend to do that, so let me hear from you and the pharmacist. Thank you.
Yeah, the statins in general do tend to have a higher risk of progression to new onset diabetes. That has come out. Jupiter sort of brought it to the forefront. Meta-analysis have confirmed that. It's not just with Rezuva, it is with high-intensity statins more than lower-intensity statins in general. And it is more with patients that have components of the metabolic syndrome. So the more they have impaired fasting glucose, central adiposity, higher triglycerides, low HDL, all those components are more likely to be moving towards diabetes. So in essence, you're saying that there are patients who are standing on the precipice anyway of moving to diabetes, and maybe the statin gave them a little extra nudge. And I think that may be true. There is some genetic evidence to suggest that, working through the LDL receptor, that there may be a higher risk of diabetes. So they've looked at things that stimulate the LDL receptor. Patients may be at higher risk. So it doesn't seem to be the case with ezetimibe, doesn't tend to do that. Bile acid resins, as you know, colesevelam increases the LDL receptor, lowers LDL, but actually reduces A1C. So there maybe is something specific to the statins. We don't know about PCSK9s, monoclonal antibody inhibition. It does not appear so far to push people towards diabetes, new onset diabetes, but honestly, I don't think there's enough data yet to know that for sure. Over time, it took us a while to figure it out with diabetes, with statins. So it does happen with statins, but remember, statins are going to reduce events in these high-risk people and overwhelm the small number of people who would just be nudged towards diabetes where they were headed in that direction anyway.
And my bottom line, just real quick points, I agree with what's been said. There is an increased risk. It is small. The benefit still outweighs risk. It is a dose-dependent phenomenon, and even at the high dose, it still is a small increase. I'm not convinced it's different across the statins. I think it's related to the potency until I see data that indicate otherwise to me. I know you mentioned pitavastatin, but pravastatin has also been said, maybe that doesn't have, I'm not sure that's true or not. I
agree.
I would rather view it as a class effect, but still a small one. And the last thing that was mentioned, if patients don't have any risk factors for type 2 diabetes, I'm not worried about the statin doing anything harmful. It's those that have other risk factors that may be pushed into it. And I heard it worded at Lipid Academy this morning from one of our esteemed experts that it's really, it's nudging people into diabetes that eventually probably will be there anyways.
Right.
I think that might be a good way to position that with patients, because that's going to be our barrier when they bring it up and they hear about it and they don't understand.
Because what you want to do is those who are on the precipice anyway, that you should be talking to them about exercise, diet, weight reduction, those kind of things anyway, if you're going to use a statin, because you need to keep them off that edge and move them away from metabolic syndrome and insulin resistance. So.
Joe, do we have any mechanism to explain this phenomenon?
Great question that I was asked today, and I'm going to give you the same answer. The question is, what is the explained mechanism of increasing propensity for new onset diabetes? I have not seen a clear one. I think we're still working on it. There's slight increases in both in people without a history of diabetes. The one thing that I have noted is that you don't see a worsening of diabetes control in those with established diabetes, it's just those people without diabetes at baseline. So it's a small increase in both. That's why the FDA says to monitor glycemic parameters occasionally on statin therapy via either fasting blood glucose or A1C.
Yeah, they've tried to do studies on statins, whether it affects insulin release by the pancreas, first phase insulin release. Some have said maybe yes it does, some say no it doesn't. Others tried to look at peripheral insulin resistance like at the muscle level. Some said maybe there is a little there, some said no there isn't. So there isn't really a statin mechanism to insulin action either peripherally or released by the pancreas. So it's not clear what the mechanism really is. So it happens, but we're not quite sure.
Next Nobel Prize, we'll be figuring it out.
Yeah, that I don't think it does. I don't think it increases glucose production. It's either going to be insulin release or insulin sensitivity peripherally rather than gluconeogenesis. Those, I think they've said it's not gluconeogenesis in the liver. It's one or the other. And there's some to support both of those, insulin sensitivity at the muscle or insulin release, and then just as many that said, no, we didn't find it.